In this sketch, we're going to illustrate the causes and manifestations of hyperthyroidism. Along the way, we'll highlight a couple of nodular thyroid conditions that cause the gland to autonomously pump out hormone. But we've traced the main source of all this illegal thyroid hormone to one location: the secret underground, unsure if pun intended there, headquarters of the criminal organization known only as Grave. See that outrageous red bow tie worn by our agent? That's our recurring symbol for hyperthyroidism. T3, the activated form of thyroid hormone, exerts its effects by entering the cell nucleus, binding to nuclear receptors, and regulating gene expression. This happens in pretty much every cell in the body. So, as you can imagine, in the setting of thyroid hormone excess, the physiologic consequences are numerous. Many of the classic symptoms of hyperthyroidism arise due to stimulated thermogenic mechanisms and increased metabolism. Just check out this ravenous dog here, seconds away from metabolizing its victim. Increased metabolism causes weight loss despite an increased appetite. Hence the lean physique of that Doberman. Gotta keep him hungry for that fresh meat. Thyroid hormone also stimulates thermogenesis, or heat production, leading to heat intolerance and excessive sweating. Patients have soft, warm, flushed skin because of peripheral vasodilation. Both hypo and hyperthyroidism can cause cramping and proximal muscle weakness. In hyperthyroidism, it's referred to as thyrotoxic myopathy and typically does not cause an increase in creatine kinase. In contrast to hypothyroidism, you don't really see much muscle atrophy either. So, yeah, the pathogenesis of myopathy in the setting of hyperthyroidism isn't quite clear. It may be due to increased metabolism and energy usage by the body, protein degradation, or inefficient energy usage by muscle cells. Either way, it usually manifests as proximal muscle weakness, such as hip flexors and quadriceps, which would explain why our secret agent is having so much trouble getting up from his hiding spot. Struggling a bit. He'll get there, don't worry. All right, time to get nervous. Hyperthyroidism goes hand in hand with increased sympathetic nervous system activity, highlighted by the name of the cemetery. Now, the interplay between thyroid hormone and adrenergic action is pretty complex, and thyroid hormone exerts many adrenergic-like effects all on its own, without help from the sympathetic nervous system. For example, part of thyroid hormone's action on cardiac myocytes is to regulate calcium cycling and increase heart rate and contractility. Nevertheless, it's pretty clear that many systemic effects of thyroid hormone are synergistic with sympathetic nervous system activity, and thyroid hormone is even known to increase beta-adrenergic receptor expression in various tissues throughout the body. Hence those beta-bugle cherubs decorating the cemetery wall. Think of hyperthyroidism as a state in which the body's response to catecholamines is exaggerated. Sympathetic overactivity is thought to contribute to the classic symptoms of nervousness, irritability, and tremor. Hyperthyroidism can even cause cognitive impairment and confusion, especially in the elderly. Patients might even have a deer in headlights or staring appearance from excessive sympathetic action on the superior tarsal muscles. You might also notice what's called lid lag, in which the sclera is visible above the iris when a patient looks downwards, as if the eyelid was lagging behind. Via direct action of thyroid hormone on cardiac myocytes, as well as enhanced sympathetic activity, patients with hyperthyroidism present with increased heart rate and contractility. In fact, cardiac output can increase by as much as 250%, as depicted by the generous output from that heart-shaped flashlight. Many patients experience tachycardia and palpitations at rest. Systolic hypertension is also common. And take a look at that screen displaying a human heart. That irregular line of static is meant to remind you of the irregularly irregular heartbeat characteristic of atrial fibrillation. Patients with hyperthyroidism are at increased risk for premature beats, supraventricular tachycardia, and atrial arrhythmias. The most common rhythm disturbance is atrial fibrillation, which occurs in up to 20% of patients. All right, a couple more clinical effects of excess thyroid hormone to mention before we complete our picture of the classic hyperthyroid patient. In contrast to the delayed and prolonged reflexes seen in hypothyroidism, patients with an overactive thyroid have brisk, exaggerated deep tendon reflexes, as depicted by the rapid movement of that reflex hammer. Hyperthyroidism also increases gut motility, leading to diarrhea, which can promote malabsorption and exacerbate weight loss. Lastly, thyroid hormone stimulates bone resorption, and patients with hyperthyroidism may have mild hypercalcemia. Remember that hypercalcemia can actually suppress PTH and vitamin D production. which can further promote the development of osteoporosis, especially in older women. Recall from the first video in our thyroid series that hypothyroidism can culminate in acute myxedema coma, a medical emergency. Well, untreated severe hyperthyroidism can lead to its own rare, life-threatening condition known as a thyroid storm. Just look at the ridiculous size of that bow tie worn by Dr. Storm. Thyroid storm presents with severe symptoms of thyroid toxicosis. This includes cardiovascular symptoms such as acute congestive heart failure, tachycardia, and deadly tachyarrhythmias, symbolized by the vibrating transmitter sitting on our expired agent's chest. Fever is common as well, with temperature soaring over 104 degrees. There can also be GI symptoms, like vomiting and diarrhea, leading to hypovolemia. Another key feature of thyroid storm is CNS dysfunction, ranging from agitation and delirium to stupor and coma. Though thyroid storm can occur in any patient with long-standing untreated hyperthyroidism, there's often an acute precipitating event, such as an infection or trauma. It can also occur when patients with hyperthyroidism discontinue their use of antithyroid medications. Thyroid storm can also be a complication of surgery in hyperthyroid patients, as emphasized by the scalpel-themed fence in the back. This includes non-thyroid surgery, as well as surgery on the thyroid itself, such as thyroidectomy. This is why patients with hyperthyroidism are often pre-treated before an operation. Generally speaking, treatment of thyroid storm consists of anti-adrenergic drugs, propyl uracil, potassium iodide, and corticosteroids. Check out the Thyroid Farm video for more details. So, how do we make the diagnosis of hyperthyroidism? As you can imagine, serum T3 and/or T4 levels will be high. However, just like we saw in hypothyroidism, serum TSH is the best screening test. Because our symbol for the thyroid is a bow tie, thyroid stimulating hormone, or TSH, is a bow tie getting tightened, stimulated, if you will. In the setting of hyperthyroidism, excessive amounts of thyroid hormone exert negative feedback onto the pituitary, bringing TSH levels down. So, to convey low TSH in the setting of hyperthyroidism, we've drawn in one of Dr. Storm's henchmen caught in the middle of tightening his bow tie as he gets taken down by our secret agent. While a low TSH and high thyroid hormone tells you that your patient is hyperthyroid, it doesn't identify the actual cause. Even though we've been talking a lot about hypothyroidism throughout this chapter, we've actually already encountered quite a few clinical scenarios that involve a hyperthyroid state. Over at Dr. Hashimoto's lair, we saw how the autoimmune destruction of the gland can sometimes cause an initial hyperthyroid phase as follicles rupture and release hormone. Though this is short-lived, and it's followed by progressive hypothyroidism as the autoimmune destruction continues. Also, at Casino Rydell, we illustrated a couple of transient thyroiditis syndromes that follow a classic progression. An initial hyperthyroid phase of inflammation and gland destruction with release of stored hormone into the circulation, followed by a hypothyroid phase as the gland recovers, and then back to normal in a few weeks' time. Conditions that follow this transient course include subacute granulomatous thyroiditis, which follows a viral infection, and painless or silent thyroiditis, which was caused by a short-lived autoimmune attack of the thyroid. Also at the casino, we showed how chronically iodine-deficient patients, when reintroduced to iodine supplementation, can all of a sudden produce excessive amounts of thyroid hormone because part of their thyroid gland has become autonomous and hungry for that iodine. Well, for the remainder of the sketch, we're going to illustrate a few more common causes of chronic hyperthyroidism: Graves' disease, toxic adenoma, and toxic multinodular goiter. In fact, we're going to start with the most common cause of hyperthyroidism in the world, Graves' disease. Hence the creepy grave entrance over on the right, along with another one of those ridiculously huge red bow ties. Graves is an autoimmune disease that typically affects women more than men. There appears to be a genetic component at work here, as cases tend to cluster in families. Additionally, Graves' disease is associated with the HLA alleles B8 and DR3, as highlighted by the engraving on the tombstone. Interestingly, other risk factors include smoking, iodine or iodine-containing agents, and stress. That's right, patients with Graves' disease are more likely to have gone through some kind of physiologically stressful event in the past, such as the loss of a loved one, a car accident, or, getting abducted and dragged against your will into a secret underground lair. See those charged IgG-shaped electrodes attached to her neck? Patients with Graves' disease produce IgG autoantibodies that bind to TSH receptors right on the thyroid gland. These are activating antibodies. Remember, we're stimulating the thyroid here. The reason why these autoantibodies develop isn't quite understood, but it's thought that those specific HLA haplotypes I mentioned earlier play a role in molecular mimicry and cross-reactivity with the TSH receptor. For instance, if a virus makes a protein that looks similar to the TSH receptor, the body mounts an immune response to both the virus and the thyroid. Oops. This is a classic example of a type 2 hypersensitivity reaction. Now, it's not really known what this initial virus or insult is, but what we do know is that chronic TSH receptor activation leads to increased production and release of thyroid hormones, resulting in hyperthyroidism. TSH receptor activation by autoantibodies also causes follicular cell hypertrophy and hyperplasia, which can lead to a diffuse, non-tender enlargement of the thyroid, or goiter. Remember,